I'll be speaking about the scale of bucket. I think nowadays the way trading happens, you get technically understand technically like the stream. But gold was a part of gold. And in my practice, I still do bucket of trading, still trading the better to grow bucket. So if we look at success rate, specifically the US corporate data for the problem which is evaluated, it's actually no different if you plot the there's a primary success rate. And we could even argue that plot is a bit better. And the function, definitely plot is better. So what do I do? Equation has, for me, the important thing when it comes to retinal detachment, whether this vision has to be the OPV for me is equal and above. If there's OPV, usually I would do it carefully, although in some cases where the detachment is limited, I was going to do above. And the reason is if you have UPVD, that it's a big problem, right, to try to separate the pictures. And also some cases are myopic, not separate. If we manage to get the pictures up, then that will open, in this case here, that will remove the detachment. And even use the check to be able to separate the high low. So I think it's best avoided. And for these cases, I just usually do segment the buffer. I'll show you some cases quickly for the sake of time, and I'm very happy to discuss any of you want talking more over coffee. Because I something that has taken time. That's usually what I do back on the video publish. And I put the video or I put it as a should. I'll show you a few cases. This is the first case. Patient had a toxic retinitis. Healed. Then 2 years after he developed retinal it's a 30-year-old patient. Only extraction membrane. In order to reject, you end up to be retinitis. But I couldn't find that thing. That's been one of my very limited indications for it. So I know that there's a break somewhere, but I really can't find it. So I did the drainage and the CC air. Never found the air. It's somewhere there. Otherwise, I do for segmental buffer. This is a patient, for example, here who had peripheral letters, which was later in prophylaxis. And after the laser, as you see here, after laser, this patient developed a retinal detachment. I'll show you this. So here we open. And then after that, usually we put an illumination with a chandelier. With the muscle block illumination with a chandelier or an illumination. And then you can see the detachment starts with this laser area. And again, the layer is somewhere there. So it's a small area, you can just put a buckle. And this patient had maybe detachment to our horizontal buckle, just one suture there. And that's enough to support this area. This is good volume, we came back and we made the paper on top of the retina. So that's usually what I tend to do. I'll show you another case. This is a patient with sort of gold there, down there, and a retinal detachment. So in this case, we did the same technique, but we elected to a radial buckle just with the localization. And then placing the same buckle but radial center of the vein. And when you do a radial buckle, the localization is very good. The leeway of errors is not like we're giving as segmental. And mind you, this case actually was done by the senior resident who was scrubbing. And so I think it gives another line to the surgery. And the retina is well and the vision equal to 8. Actually, just one last slide. And I'll show you this last case here. This is a patient who had a macular bone and a retinal detachment from pleural dialysis. So the question to put it objectively or to do what we do for the patient, and we ended up doing again just a segmental bottom with no training. But this patient did very well, and so I think my message from this and the whole group, my message from this is the mental bottom improvement skill, what is that chandelier is very useful in another one. I think it's something that I want to do.
Thank you a lot, Dr. Ahmed. Dr. Mohammed Maghazi, do you have any question or?
Yes, Ahmed, thank you very much. And indeed, it's a forgotten art that needs to be revived. The thing is, do you consider a buckle with a case of vitrectomy? Would you add a buckle to a vitrectomy case in any scenario? Yeah.
I don't like something like any time where the patient has some PPR which should not be now required, then I would insert otherwise.
I never use a buckle with a vitrectomy. I don't think it's. I mean, the way we put the buckle, we put it at the equator. We're not supporting the vitreous base, and I think with the new advances in the illumination and the visualization systems and the very advanced machines now, we don't need a buckle anyway. If you're going for vitrectomy, you don't need a buckle.
So yeah, I think PPR next. It has not enough.
Salam, thank you for supporting the chandelier buckling. The only man who had found to support me in this aspect. I just want to ask you about the type of chandelier you use, because this is critical. Some chandeliers, like some companies, are very stiff and you may hit the lens during your maneuvers. And some have a large caliber and you may induce vitreous incarceration inside of the chandelier. So I think you have to select a chandelier which is very flexible and again with very small gauge, so that you don't incarcerate and you don't traumatize the lens.
Yeah, actually I don't use the chandelier, I use the end. So I put a trooper which is something that sorry.
And you hold it at the same time?
Yes, I will. I keep the light moving checking the and otherwise, when I use chandelier, and then you get the eye tips for you, so then I just connect the light.
But I think this is very difficult to manipulate the endulum.
It's not difficult, and it gives you the same feeling that you're doing a trick. It's always opposite.
Okay.
So I think with practice, I feel it's easier, and that's what the fellow does.
Of course, I agree with you with for the use the external annotation. I want to ask you about use chandelier in the external annotation. It's not over to do internal surgery. Why? Because you can use it with slit lamp in the microscope, for example. That's the first thing. Second thing, I agree with you for the indication of scleral buckle in for example for young people, clear lens, inferior retinal detachment, and with hole. And for me, my experience when I associated with tear, for example, you have a double of risk of recurrent detachment. What is your feeling about this?
So yeah, I think slit lamp is nice. The problem is in the US and except in France, and I think the Morocco and Algeria. I think I know a lot of you are trained in France. This slit lamp microscope is not really available, and we cannot get the disposable 20 lens. So for us, that doesn't work. So we have to refer to this. And I think it's very important to give another life to buckle. And I couldn't see many of the cases, but in some of the cases I was not even scrubbed. I was just in the room and the fellow was doing everything. As for buckle, I think yes, no PVD detachment buckle is a straightforward surgery and the success rate is very good. PR, I think, is better. No matter not to not show that, but I think it's a very useful surgery.
Thank you.
May I ask one question?
Please.
So only a comment in selected cases, in the pediatric cases with PVR, we quite often consider vitrectomy with unsyncing band, just to, let's say, give last chance to the patient.
Thank you, Dr. Robert. I think severe buccal has a lot of controversy. Segmental versus 360, a joint with vitrectomy or no, and is it a dying technique or something we have to keep it? So I think this is need a special session rather than a talk. Thank you very much, Dr. Ahmed. I think our next speaker is Dr. Baha Abdullah for submacular hemorrhage. What's next?